Hi, thank you for joining us. I'm Mohammed Bashir, and today I'm sat here with Dr. Duke Cameron. It's an honor to spend time with him today to give us a talk about valve-sparing aortic valve repair. Dr. Cameron, he's been with us before on the CTSNet giant interviews. We learned a lot from his tremendous contribution to this particular interview. And today, I'm just going to shift gears and ask him on different angles on this particular topic, and so that we can also learn more from what he has to say. As you all know, Dr. Cameron is the cardiac surgeon in charge at Johns Hopkins Hospital, and he is the director of cardiac surgery at the Johns Hopkins University School of Medicine. Dr. Cameron, thanks very much for joining us today.
Thank you very much, Mohammed.
My first question to you today is valve sparing repair the operation of choice in non-Marfan young patients?
Well, I think we don't know the answer to that yet. The operation of choice has to be a safe operation. I think we know that it is a safe operation when performed by people who are experienced root surgeons. We know that it has good results out to about 10 to 12 years in patients, young patients who leave the operating room with a competent aortic valve. But we don't know how the operation behaves out at 15 or 20 years. And a good operation really should behave well out to 20 years. And we'll have to wait a little bit longer before we know. But I still think that for young patients, for whom the advantage of avoiding a valve prosthesis are particularly attractive, I think it's a good operation to offer people, recognizing that we don't know the durability of it yet.
Right. What factors makes you arrive to a decision that this patient is suitable for a valve-sparing procedure?
Well, first of all, it's important to remember it's an operation for aneurysm disease, not really valve disease. So these are typically young patients who have connective tissue disorders like Marfan syndrome or Loeys-Dietz syndrome, some patients with bicuspid aortic valve, patients where the aortic root is dilated. The mid-ascending aorta may or may not be. It doesn't really impact whether you can offer that operation. But it's primarily a sinus disease where the aortic valve still is functioning reasonably well. Various degrees of regurgitation can be corrected when you change the geometry of the aortic root. But most patients with a tri-leaflet, well-formed tri-leaflet aortic valve can have this operation with the expectation that they will have a competent aortic valve at the end. But the main purpose of the operation is to prevent aneurysm rupture, and I think that's an important point.
You surely agree, and I heard you yesterday mentioning that it is a technically challenging procedure with results that can't be actually replicated in hands of different surgeons. What's Duke Cameron's way?
Well, we have a simplified technique, and it's really the David procedure. But I think we've distilled it to a few key steps and a few key components of the operation that make it both easier to understand but also easier to perform. I think we've just simply deconstructed Tyrone David's operation into steps that people can understand, and it has been a replicable operation in people who've trained with us, who've gone out and done this operation on their own, and through various training courses and such. I think we've shown people how to do this operation, and I've heard back that in other people's hands it has worked well. But the operation, the steps are that first one has to assess the aortic root, determine if the valve is a salvageable and preservable valve, make a determination about the size of the graft that one should use, which we base mainly on an eyeball assessment of the optimal sinotubular junction diameter. That diameter which brings the leaflets back into this, what we call the position of prayer, which is really the anatomic position of a normal aortic valve, where there's a large area of coaptation, and that the area of coaptation is in the middle of the sinus. You can't have the valve closing like this, or worse, this. But that position of closure of the valve, El Khoury also describes it as if the patient is applauding the operation. That's what one strives for, and choosing the appropriate prosthesis that delivers the valves into that position is the key step. And there are a few other tricks for choosing that. One can measure free leaflet edge. You can measure the height of the commissure between the non and the left sinus, and add a few millimeters to that, and that will also produce the graft size. Or, as we joke, you can usually use a 30 millimeter graft, and that works for most people if you're really having trouble sizing it. And then we've simplified the operation by just putting 3 sutures at the bottom of the root. Now, these are subannular sutures, pledgeted 2O Tevdex, and they're placed from the inside of the left ventricular outflow tract outward below the valve, just at the nadir of each of the 3 sinuses. And if it's a bicuspid valve, it's just 2 sutures. And these sutures simply anchor the graft to pull it down so that the entire root complex is within the graft, and that prevents annular dilatation, which is really important for these young patients with connective tissue disorders. Then that internal hemostatic suture line is just as Dr. David described it. The coronary implants are the same, and the distal or top end of the anastomosis is straightforward. Generally, with Marfan syndrome patients, and those are the largest group of patients that we see in our practice, it's not necessary to extend this resection out into the arch. If the arch isn't dissected, it's not likely to dilate later on. So prophylactic replacement of the arch really isn't necessary. When one brings the graft in and the valve is now closing in this way, well, sometimes when you bring the graft in, because the graft is always smaller than what the aneurysm was, you can induce some leaflet prolapse. And if you see that, then you have to deliver that leaflet up so that all of the leaflets are actually at the same height and coapting well. And so about 20% of our patients require some plication of the free edge of the leaflet, which is usually just with a simple Gore-Tex suture. That makes a lot of sense in my mind to do it there rather than a running suture along the free edge, simply because in Marfan syndrome that free edge of the leaflet is so thin, I don't think it holds a suture well. Whereas the mid portion of the leaflet lends itself very well to a little folding plication. By shortening that free edge, the leaflet is pulled up and matches the height of the other 2. So I think those are the key steps are extensive dissection of the root. You really have to dissect all the way down to the bottom of the sinuses in all 3. The choosing of the graft, which we do based on optimal sinotubular junction diameter. Then the 3 subannular sutures, the pulling down of the graft, tying those sutures. The commissures are also tacked up at the sinotubular ridge of the graft. And if you choose the graft correctly, then there's not a lot of guesswork where to put the sutures or where to put the commissures. This is, I think, one of the problems with some of the other techniques where especially younger surgeons are having trouble deciding where to put those commissures within the graft. If you use the Valsalva graft and have chosen the right size graft, then the commissure almost always goes at that sinotubular ridge of the graft. It takes the guesswork out. So after the commissures are fixed at the sinotubular ridge, then the internal suture line is done, the coronaries are implanted, distal suture line. It's a sequence, it makes sense, and there are a few critical measurements along the way. But I think, as I say, it can all be deconstructed into an understandable, rational operation.
Great, great. What data can you share with us on valve sparing procedures and Marfan or low DEETs in your own hands and experience?
Our experience now is well over 300 patients. Quite a few of them are young patients. In fact, our youngest was about a year of age. The average age is about 30. And the vast majority of them have, more than 2/3 have Marfan syndrome, which is unusual. Most other valve sparing series, the proportion of Marfan is 20 or 30%. So it's an unusual series in that respect, in that they're younger patients, many more Marfan syndrome patients. Of that series, there's one hospital mortality. It was a very young child who had both a root replacement, valve-sparing root replacement, and mitral repair, very severe Marfan syndrome patient who had, unfortunately, catastrophic sudden hemorrhage hours after surgery, and though was resuscitated, suffered a fatal neurologic injury. There have been no other deaths, so the operative mortality in the series is under 1/3%. So we believe it's a safe operation. The series includes a small group of remodeling operations that were done in the very early part of the series, until we learned that the annular stabilization that is not provided by the remodeling was a problem. They developed late regurgitation. Although it's not to most patients, but it was a healthy enough percentage, 20 or 30%, that needed reoperation for AR. So we abandoned the remodeling. We've gone into the reimplantation. And in the Marfan series, at least the last update, of the patients who had tri-leaflet aortic valves and a reimplantation, there have been no reoperations in the adults. There have been a couple of children who've developed some regurgitation later on and needed replacement of the valve. But in the adults, it's been a remarkably durable operation, now at over 10 years.
Okay. We're just going to move to a different setting. Would you do a valve-sparing procedure in an emergency dissection setting?
Well, yes, we would, and we have done a very limited number. Certainly, there's nothing about a dissection of the sinuses that anatomically precludes this operation. But it's a longer operation than a Bentall. It is an operation where the results are not as certain at the release of the cross clamp, and in my own view, probably not the best operation in any setting where there's any instability of the patient or concern about lingering malperfusion. I do subscribe to the philosophy that the main point of dissection surgery is to produce a survivor, and whether or not the valve is saved is entirely secondary. But a young patient with an acute dissection, hemodynamically stable, particularly if it's a DeBakey 2 where the chance of a near cure is possible, yes, we do consider it, but we don't push hard for it in the acute dissection setting.
Right. Would conversion to Bentall intraoperatively be a big worry to you?
Well, insofar as it does extend the cross clamp time and bypass time, yes. But I think your question brings up an important point. If you do a valve sparing and intraoperatively, you cannot salvage it, either because of bleeding or aortic regurgitation that is more than mild. What should you do? And first of all, if the problem is bleeding from the base of the graft, then you really must take down the whole operation and start all over again from and do a Bentall. I like to say you really shouldn't do a valve sparing unless you can do a valve sparing and a Bentall to follow with reasonable safety. But if the problem is aortic regurgitation and you've not been able to sort out why, and that does happen sometimes, and can't fix it, then you have the option of simply opening the graft, excising the valve, and putting a prosthesis within the graft, which is which takes a lot less time than a Bentall. But it has to be a large enough graft that you can fit an adequate size prosthesis. Most of the patients we operate on already have a somewhat large annulus, so it's not a problem. But in some older patients without connective tissue disorders, the graft may not be large enough to accommodate an adequate prosthesis. And in that situation, you have to do the complete Bentall.
Sure. Dr. Cameron, in your experience, have you had any valve sparing coming back for a redo procedure?
Well, as I mentioned, we've had that few number of patients, mainly the children, where they came back with aortic regurgitation and had the valve replaced without having to do the entire root replacement again. We've had a curious small series of Loeys-Dietz syndrome patients who have had pseudoaneurysms at the base of the root graft. These are patients, half of them were operated on at our institution, half were operated on at other institutions using other techniques of valve sparing. So I don't think it's a peculiar complication to our method of valve sparing. But these have all been in the non-coronary sinus, and they've all been from the sutures that are subannular, tearing through the aortomitral apron, leading to a pseudoaneurysm at the base of the non-coronary sinus and the roof of the or dome of the left atrium. And these have all been repairable without giving up on the valve sparing. You open the graft, retract the leaflets, and then you usually find a small narrow neck to the pseudoaneurysm that can be closed either with a small prosthetic patch, or if it's a smaller one, just closed primarily with several mattress pledgeted sutures.
Great. We hear a lot of reports about aortic incompetency post valve sparing repair. Is that a worrying factor to you? Does it concern that you're hearing a lot of AIs happening after this particular procedure, and if it happens, in your own words, what's deemed to be acceptable? This is an acceptable AI.
Well, there's aortic regurgitation that's early, or even intraoperatively, and then there's aortic regurgitation that's late. And aortic regurgitation in general, that's the Achilles heel of this operation. Yeah. I think it's very unusual to have aortic regurgitation appear late that wasn't there to some extent in the operating room. So I think a lot of it is still preventable by attention to that position of prayer and making sure that, in particular, that there's no eccentric regurgitation. In the operating room, at the end of the case, a small amount of central aortic regurgitation that goes straight back from a central orifice, that's often just because of the thickening of the nodules of Urantius. And I think that's stable and rarely is of any hemodynamic consequence. On the other hand, a regurgitant jet that is eccentric, that hugs the undersurface of one leaflet, speaks to prolapse, even if it's not readily appreciable that there's a prolapse leaflet. An eccentric jet usually means prolapse. And that is a progressive problem. That rarely stays stable because the leaflets aren't supporting each other. It means that one's down like this, and it will continue to get worse. So that needs to be addressed, and certainly anything 2+ or more in the operating room really needs to be fixed or addressed before leaving the operating room. Now, aortic regurgitation that is late, I think the indications for reoperating on those people are the same as indications for operating on any aortic regurgitation lesion. I think one interesting question is whether or not these patients will be TAVR candidates. They have a rigid, perfectly round graft, which could be an ideal environment or landing zone for TAVR cases. On the other hand, these are usually young patients for whom the TAVR valves may not be that durable. But it is a fairly simple operation, as I said, to reoperate, open the graft, and simply put a new prosthesis in, a new valve prosthesis, without redoing the whole root. And that's low risk. Whether the patient at that point wants a mechanical valve or a bioprosthesis, that's patient choice.
Great. Dr. Cameron, I know you've got a long day waiting ahead of you today, but thank you very much for spending some time with us. It's been an honor.
It's been my pleasure. Thank you very much.